Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of. Today we will discuss Alport syndrome. This topic is very important as per practice point of view or theory point of view because Alport syndrome is hereditary nephritis means any nephritis disorder which is hereditary or getting in two families, that is hereditary nephritis, that is Alport syndrome. What is Alport syndrome is essentially it is a heterogeneous disorder. Basically in basement membrane type 4 collagen is there, and the some disturbance in the type 4 collagen is there. So Alport syndrome basically a basement membrane disease. In basement membrane type 4 collagen is present. Pathological variants in that type 4 collagen leading to Alport syndrome. So this is basic introduction of Alport syndrome. Let's dive deep into it. What are the genetic patterns or inheritance pattern of Alport syndrome? It is actually can get X-linked inheritance, autosomal recessive, autosomal dominant. All inheritance are possible, but the most common inheritance is X-linked inheritance, 70 to 80% of cases. So this is important. Most common of inheritance pattern in Alport syndrome is X-linked. Gene is alpha 5 chain of type 4 collagen. Type 4 collagen will be remain same. The chain will different. So alpha 5 chain. So call A4, A5 the short form of this. So basically just remember 5. So X-linked inheritance is alpha 5 chain of type 4 collagen. This is most common form of Alport syndrome because it is seen in 70 to 80% of cases as we can see. Okay, the peculiarity of this pattern is it has some association with diffuse leiomyomatosis. This condition is seen in esophagus. Just remember, X-linked is the most common variant seen in 70 to 80% of cases, seen in type 4 collagen alpha 5 chain, and it is associated with diffuse leiomyomatosis. Second pattern is autosomal recessive, which is seen in only 5% cases, and alpha 3 and alpha 4 chain of type 4 collagen. Just remember, in X-linked inheritance, it was alpha 5 chain, and in autosomal recessive, this alpha 3 and alpha 4 chain. And this is less common but associated with severely early onset disease. Okay, again a question. If Alport syndrome presents early and severe, just think of autosomal recessive inheritance of this disease. Next pattern is autosomal dominant inheritance. Second most common is autosomal dominant. So first X-link, next is autosomal dominant, next is autosomal recessive. So this is actually second most common, and protein are same like alpha 3 and alpha 4 chain of type 4 collagen. Okay, are there any syndrome associated with this? Yes, there are many syndromes. Just remember two syndrome, Fashner syndrome and Epstein syndrome. So just remember both syndromes are similar and similar presentation. What happened? Platelet count are low, but platelets are large. This is very important. Large, low platelet count. This terminology is, is called as macrothrombocytopenia. This is very important. Macrothrombocytopenia seen in which syndrome? Fashner syndrome. And which gene is associated? The gene is MYH9 gene. So, this Fashner syndrome having similar features with Alport syndrome with macrothrombocytopenia, gene is MYH9. The similar syndrome is Epstein syndrome with similar looking anomalies. Other important syndrome which mimics or which create diagnostic confusion with Alport syndrome is HANAC. The full form is hereditary angiopathy with nephropathy, aneurysm, and muscle cramps. Basically, this is kidney and some CVS anomaly combination. So, gene is because this name is very large, this should give preference. Again, alpha 1 mutation. So, because this name is very big, very large, so alpha 1 is the chain. Okay, so this having vascular complication as name is suggesting hereditary angiopathy with nephropathy, aneurysm and muscle cramps. Okay, so in summarize the genetic pattern which is important because this is itself called as hereditary nephritis. So as we can see, this is X-link is most common. The gene is alpha 5. This is most common. Autosomal dominant is second common, alpha 3, alpha 4. Autosomal recessive third common, alpha 3, alpha 4 gene. But just remember, autosomal recessive severe early onset. Syndromes like Fechner and Epstein syndrome associated with macrothrombocytopenia and gene is MYH9. Another syndrome is HANAC, full form we have just discussed. The gene in call A4, A1 alpha 1 gene and resembles AS include aneurysm. So this tables basically summarize the genetic pattern of Alport syndrome in brief. Okay, now we will discuss pathology. Okay, so basically this is glomerular basement membrane disease because of collagen 4 abnormalities. If we will do light microscopy early stages, it may be normal. Just mesenchymal proliferation, capillary wall thickening may be seen, otherwise it is normal. In advanced stages, as we know, sclerosis develop, tubular atrophy develop, interstitial inflammation fibrosis, and presence of foam cells. So this is important. In many conditions, foam cells are seen, but this is one of the conditions in which foam cells are seen. So foam cells are lipid-laden tubular and interstitial cells. Immunopathology, generally it is non-diagnostic. Electron microscopy, this is star of this discussion. Electron microscopy, you can see thickening of GBM, glomerular basement membrane. Thinning also means it is thickening, thinning, and splitting. This is actually severe form suggestive of severe form. But as of now, remember, electron microscopy findings are pathognomic of this Alport syndrome. It may be in form of thickening, thinning, splitting. The thickening is seen in severe spectrum of Alport syndrome. The diagnostic challenges because it may, if you do this, it may be normal. So these are diagnostic challenges. Just see electron microscopy is showing thickening, thinning and splitting. So somewhere it is showing thickening, somewhere showing is splitting and somewhere is thinning. And just remember thickening is seen in severe disease. So we have discussed genetics, we have discussed pathological renal biopsy finding, how this Alport syndrome presents. Basically, just remember this actually triad of renal, then ear and eyes. So this is a simple drawing. Eyes, ear, eye and kidney. So basically, triad of these systems are basically involved. We are discussing this disease, Alport syndrome, under heading of nephrology. So renal manifestations are more common. In renal manifestation, microscopic hematuria seen in all patients. Okay, so microscopic hematuria seen in all patients. So which abnormality is most common renal abnormality in these patients is microscopic hematuria. It is asymptomatic, intermittent, often seen in females. So this is seen more common in female to male ratio. Gross hematuria seen in 50% patients 1 to 2 days after upper respiratory infection. So in remember, gross hematuria, though we discuss this Alport syndrome under heading of gross hematuria, but microscopic hematuria is seen in almost all patients, more seen in female, and it is far more common or double common than gross hematuria, which is seen in 50% patients. Proteinuria. So this is seen in male. Okay, so just see the analogy. The asymptomatic microscopic hematuria seen in female, but this proteinuria is more common in male. In female, it may be absent, mild or intermittent. So just remember, the female are excreting more hematuria, and the male are excreting protein. So just remember anyhow, but this is important. So proteinuria become progressive and exceed 1 gram per 24 hour. It may exceed. Severe cases may result in nephrotic syndrome. Okay. Then ear manifestation, we have discussed nephrotic renal manifestation, the auditory manifestation. Bilateral SN sensorineural hearing loss. This is pathognomic of this finding. If you found renal disease and some bilateral sensorineural hearing loss, this is very pathognomic. But just remember, this is non-congenital. This is has been tested many times. Non-congenital means it develops later. High frequency loss. It is not low frequency loss, high frequency loss. Does it correlate with renal function decline? Yes, it correlates with renal function decline. And prevalence seen in X, more in X-linked Alport syndrome, more in hemizygous male than heterozygous male in autosomal recessive cases, 67%. Basically, the key takeaway from this discussion is 90% of hemizygous male with X-linked AS are more commonly affected with bilateral SN hearing loss, which is non-congenital, which is of high frequency loss, and it correlates with renal function decline. Next, eye. Next in triad, eye. It is seen in 30 to 40% patient of X-linked AS. What is it? Anterior lenticonus, lens bulging into anterior chamber. As we can see in this image, lens is bulging into anterior chamber. Remember, this is not posterior lenticonus, it is anterior lenticonus. Other two findings are important, like macular flex and corneal erosions. So these are also important. These are macular flex and corneal erosions. Other systemic features we have seen X-link pattern. Leiomyomatosis is seen, although it is rare, but is seen in esophagus, tracheobronchial tree, and female genital tract. We will summarize the clinical features in tabular form. So, microscopic hematuria seen in 100% all patients. It is asymptomatic generally, intermittent, and seen in female more than male. Gross hematuria seen in only 50% patients occur after URTI. Proteinuria is progressive and severe cases may cause nephrotic syndrome. SN hearing loss, 90% male, hemizygous male, and begin high frequency range, progress with renal decline, and it is never congenital origin. Ocular abnormalities seen in 30 to 40% patients, including anterior lenticonus, means anterior bulging of lens into anterior chamber, macular flex, leiomyomatosis. Okay, so this is a rare condition. How you will diagnose? Okay, so diagnose actually many criteria like family history, urine analysis, audiometry, ophthalmological examination we have seen we will do. But any diagnostic criteria are there? Yes, diagnostic criteria. So what are those? Just remember three systems in this: renal system, auditory system, and ocular system. So take one manifestation from this system. The star is hematuria. So hematuria is with at least two of the following. Okay. So hematuria must be there to diagnose Alport syndrome. Any two. So just remember from eye, it is macular flex and recurrent corneal erosions. Note the anterior lenticonus. Just remember anterior lenticonus is not a part of diagnostic criteria. In kidney, GBM changes on electron microscopy like thickening or thinning, and ear point of view, SN hearing loss. So any two, this is very important. This thing has been asked multiple times. Key diagnostic criteria of Alport syndrome: hematuria with at least two of like macular flex, recurrent corneal erosion, GBM changes, and SN deafness. Okay, if we do skin biopsy, we generally don't do. If we do skin biopsy, obviously it is alpha 5 chain. Just remember, in male it is absent staining, but in female it is discontinuous staining of alpha 5 chain. Very much important. Genetic testing, obviously we can do. Prognosis, the risk of and stage kidney disease is varied. Okay, what are the risk categories which are in high risk? Okay, so if it is hemizygous X-linked AS, it is more. Homozygous autosomal recessive, it is so. This is X-linked and autosomal recessive are more at high risk. And stage kidney disease occurrence seen more in X-linked hemizygous 75% by age of 30, X-linked heterozygous by age 40, X-linked heterozygous by age 60. So basically 75% of X-linked hemizygous. Just remember, X-linked hemizygous are more prone to this end-stage renal disease by age of 30. Okay, so yeah, so in this, uh, just wait. Okay, so in this, where we are, huh. So poor prognostic factors. What are the poor prognostic factors? Like gross hematuria during childhood, development of nephrotic syndrome, and severe GBM thickening observed on renal biopsy. We have discussed severe GBM thickening. Intrafamilial variability is also there. What is the treatment of Alport syndrome? Actually, there's no curative treatment is available. ACE inhibitors and ARB, as we discussed, they slow proteinuria and improve renal functions. Renal complication like hypertension, anemia, electrolyte imbalance, we will manage them accordingly. And stage renal disease management, how you will do? You will do dialysis, kidney transplantation. The important consideration in this, 5% of recipient may develop anti-GBM nephritis, particularly male with early onset and stage kidney disease. This statement is very important. 5% of recipient may develop anti-GBM nephritis, particularly male with early onset and stage kidney disease. How you will screen or prevent? Any recommendation out there? Yes, they are. So, heterozygous carriers like X-linked AS, screen of renal disease in laterhood, early detection of proteinuria is crucial for initiating treatment to just screen for proteinuria. Okay, to summarize all these, like we will see family history, diagnostic test is pathognomic feature is anterior-lenticonus, but it is not included in diagnostic criteria. Skin biopsy alpha 5 chain absent staining seen in male, discontinuous staining seen in female. Prognosis is actually guarded. Pharmacological treatment ACE inhibitor ARP and end-stage kidney disease management by dialysis and kidney transplantation. Okay, so this was it for Alport syndrome. This is very important disease. Just go through this once again and you will get the overall picture of Alport. Yes, we'll discuss some another topic of this amazing series. Till then, do share, like, and